Thank you very much for inviting me to speak today about a study we did that received some funding from an HCF grant, looking at colorectal colonoscopy polyp surveillance. So I guess I'm not sure how many of you here do colonoscopy, but I thought just to cover what a colorectal polyp is. Basically, it's just a mass that protrudes into the bowel lumen. That's the definition of it. Often these are precursor lesions to cancers. Most of them are not cancers, but they have the propensity to turn into a cancer. And so generally, when we do a colonoscopy for any reason, if we find the polyp, we remove it, and then we send it for pathological assessment. The pathologist looks at it under the microscope and tells us how advanced the polyp may or may not be. And then we use various criteria that are decided using the guidelines, depending on the polyp size and how advanced it is, to decide when the next colonoscopy interval should be in order to find further polyps, and we go ahead and book that colonoscopy. So this is a pretty standard process that's been going on for many decades now. The previous NHMRC guidelines were fairly straightforward. There were basically 4 buckets of intervals, depending on the number, the size, and the polyp features, that you could then book the surveillance colonoscopy at 5, 3, 1 year, or in the case of very large polyps that weren't completely removed, at 3 to 6 months. And this held for about 7 years. And it matched up with the MBS guidelines for funding colonoscopy. And so it was fairly routinely used with reasonable success. However, in 2018, the guidelines were revised. And instead of having sort of a one-page flow chart, that morphed into 9 separate flow charts. There's so many flow charts that they don't fit on this one slide. And that's because polyps were split into 2 types, as well as the usual size and features. So there's a separate flowchart algorithm for typical tubular adenomas, and a completely different one for serrated adenomas, which is a less common polyp type. And then it had 2 layers. So your next surveillance colonoscopy interval depended not only on your current findings, but also on the previous colonoscopy findings. And so as a result, the number of different possibilities multiplied pretty dramatically. In addition to this, the MBS schedule was also revised, and unfortunately the MBS schedule, which is how we get paid for colonoscopy and how hospitals get paid for colonoscopy, did not match up with the new guidelines. And so you have this very confusing situation where the guidelines themselves are extremely complicated and the funding does not match the recommended intervals. So obviously this created a lot of chaos. There was widespread uproar behind closed doors, both in the colorectal surgical community and in the gastroenterology community, who are the 2 groups that do the most colonoscopies. But unfortunately, by the time the guidelines and the MBS schedules had come out, there was so many years of work behind them that it was sort of put in the too hard basket, and it was felt unfixable for the moment. At the Royal Adelaide Hospital, what we did and what I was interested in doing is at least trying to make the algorithms a little bit more palatable. So we created this website called Polyp Guide, or www.polyp.guide. And instead of having to flip through the guidelines, either physically or virtually, to find which flowchart works, you can actually use this website, which will automatically pop up the relevant flowchart that's required. And this is now used probably several hundred times a day by various clinicians around Australia. And I know at the Royal Adelaide, our polyp nurse uses this to work out the intervals for surveillance colonoscopy. So it's reduced the burden of paperwork a little bit, but can't really compensate for, fully for how complicated things have become. So we decided to add a research bow to this quiver. And in 2019, we applied for a grant to look at whether, in fact, the new guidelines have changed compliance and practice. And we were successful. So HCF gave us a couple of $100,000. We're very grateful for this. This allowed us to to build a REDCap database across 2 different hospitals and to hire the relevant staff to collect the data. Quite a massive data set, which I'll go through in a minute. So the aim of the study was to determine the impact of the new NHMRC polyp surveillance guidelines on compliance with colonoscopy intervals. We designed this as a retrospective audit to run across 2 tertiary hospitals in Adelaide, Royal Adelaide Hospital and the Queen Elizabeth Hospital. We took a snapshot at one point in time of all the patients who were currently on the list for polyp surveillance, because those patients have had a determination by a clinician or a nurse as to what the interval should be based on either the 2011 or the 2018 guidelines, and we used that data set to look at whether compliance dropped since 2018 and the new guidelines were adopted, but also to model the impact of the new guidelines out to 10 years, as far as whether this will end up in us doing more or less colonoscopies overall, which I think is something that's been missing from previous analyses. So this slide shows the REDCap database that was built. We had multiple research officers and a surgical registrar entering the data into this common unified data set, and it was helpful using REDCap to control the number of options and fields so that we could homogenize and improve the quality of the data collection that we could then export and analyze. So just to look at the results, there were across the 2 hospitals there were 4,000 patients waiting for a colonoscopy, of which about 2,000 were on the list for polyp surveillance. Now, these weren't all overdue, they were just waiting for their time for the polyp surveillance colonoscopy to come up. Some of them were a year or 5 years out, but they were on the list for a surveillance colonoscopy, having previously had a polyp found. One hospital had a considerably bigger waiting list than the other one, so it was 1,500 in one and about 500 in the other one. It's important to note that both hospitals have very different mechanisms as well. So they adopted the 2018 guidelines at different time points, but also in the bigger hospital, there was a polyp nurse that actually organized all the colonoscopies, whereas in the smaller hospital, the individual clinician who did the colonoscopy was responsible for booking the surveillance scope. So as we discussed, 2,000 patients eligible for analysis. The compliance at the time of the 2011 guidelines was about 66%, and that is consistent with multiple previous publications looking at surveillance compliance for polyp surveillance. It usually sits around 60%, so that's what we would expect. Since the 2018 guidelines, however, that has dropped to 50%, so there's a 15% drop in compliance, presumably as a result of the guidelines being so much more complicated and the lack of matching up with the MBS schedule, and this was statistically significant. Not only did compliance drop, but it dropped in the adverse direction. So clinicians and the nurse in the particular hospital were more likely to book scopes earlier rather than later. And so therefore we ended up doing more, eventually we'll end up doing more colonoscopies than we needed to as a result of this drop in compliance. So we looked at the modeling equation. So we looked at the data that we had and we said, well, what would happen if we followed the 2011 guidelines for 5 and 10 years versus what would happen if we followed the 2018 guidelines for 5 and 10 years? Initially, we looked at perfect guideline application. In other words, if compliance was 100%, if we followed the guidelines perfectly, what would happen is we would have more 10-year colonoscopies booked with the 2018 guidelines, which means we would have fewer colonoscopies over time that we needed to do. And that's because the 2018 guidelines introduced this idea of a colonoscopy at 10 years, whereas in the old guidelines, the most common was 3 or 5 years. And so the idea behind this is that low-risk patients don't require a colonoscopy every 5 years, and therefore they can be pushed out to 10 years and reduce the burden. So in fact, if you apply the guidelines perfectly in our patient population, you end up doing less colonoscopies, which is overall a better allocation of resources. However, we do have the problem of compliance and the fact that compliance with the 2018 guideline was worse. So when we looked at this in the real world, with real-world compliance, with the 2018 guidelines, you actually end up with more 1-year colonoscopies booked because clinicians erred on the side of earlier colonoscopy whenever there was confusion. And that effect is additive because when that patient comes back for their colonoscopy at 1 year, you're still applying the 2018 guidelines, and so therefore you're still more likely to do them earlier. So there's this almost like a compounding interest effect where you're going to be doing more and more and more colonoscopies. So I'll show you what this looks like in the actual numbers. So when we look at the interval recommended, forget about compliance now, this is perfect compliance, you'll see that with the 2018 guidelines, you're doing a lot more colonoscopies at 10 years. So you're expanding the timeline with which you're doing the colonoscopies, and therefore you're hopefully doing less colonoscopies per year and reducing the waiting list burden. However, when you look at actual numbers from our study, so this is with compliance factored in, you end up doing a hell of a lot more one-year colonoscopies than previously expected. In fact, there's not that many 10-year colonoscopies being booked, as much as there should be. When you look at the modeling, you'll see that, again, with perfect compliance, you should end up with less burden on the waiting list at 5 and 10 years. But when you look at it in the real world, when you look at the actual numbers, because of the lack of compliance, it's actually significantly worse. And if you want an actual, real numbers, for every 100 patients that have a surveillance colonoscopy booked using the new guidelines, you end up with 50 extra colonoscopies at 5 years due to the additive compounding interest effect. And at 10 years, you end up with 86 extra colonoscopies, which is, a fairly massive number. Technically speaking, these are colonoscopies that are non-compliant with the guidelines and therefore didn't actually need to get done, and are adding unnecessary burden onto the waiting list. So I guess it's hard to look at these data and not conclude that the introduction of the 2018 guidelines, at least at these two hospitals, has been an epic fail, because it's resulted in significantly worse compliance, probably due to increased complexity and lack of coordination with the MBS billing. And it's probably had already a significant adverse effect on waiting lists, and this is likely to continue into the future until something changes or breaks. So outside the scope of the study and the discussion, we've made some suggestions. We really strongly feel that future guideline updates should prioritize simplicity over complexity, and there should be some sort of effort to coordinate the guideline recommended interval with what the MBS funds. Otherwise, the left hand is not talking to the right hand, and that creates additional confusion and reduced compliance. Furthermore, we do have a sense that protocolized follow-up would probably improve compliance over what currently happens, which is largely human-led and therefore is subject to human errors. So whether at the very least there could be a protocolized nurse-led system or some sort of automated recall system that would approximate the guidelines better than leaving it up to the individual clinicians with their inherent biases. So thank you very much for that. I hope the talk's been useful, and I look forward to answering any questions. Cheers.